Today we're tackling endocrine disease, one of the most common reasons for abnormal chemistry panels in small animal practice. The thyroid, adrenal glands, and pancreas together are responsible for an enormous proportion of the medicine cases you'll see. And here's the thing about endocrine disease. It doesn't just cause one abnormal value. It causes a whole pattern of changes across the CBC, chemistry, and urinalysis. By understanding the hormone and what it does, you can predict which values will be abnormal and why. That's the systems approach. Every endocrine disorder fits into one of two categories. The gland is making too much hormone or too little. And here's the beautiful thing. If you know what a hormone does normally, you can reason through what the disease will look like on the lab panel. Cortisol promotes glucose production, suppresses immunity, and retains sodium. So Cushing's disease with excess cortisol gives you hyperglycemia, a stress leukogram, and sodium retention. Predict the lab pattern from the hormone's normal function, and you'll never need to memorize endocrine disease again. Hormone is the metabolic throttle for virtually every cell in the body. When the thyroid fails, which in dogs is almost always due to immune-mediated destruction or idiopathic atrophy of the thyroid gland, the metabolism slows down across the board. The classic dog is a middle-aged, large breed dog that is gaining weight despite a normal or reduced appetite, is lethargic, can't tolerate cold, and has a dull, dry coat with bilaterally symmetric hair loss. The most consistent biochemical finding is hypercholesterolemia, because without adequate thyroid hormone, cholesterol metabolism slows down and cholesterol accumulates. A mild non-regenerative anemia is also common. Always screen with a total T4, but if clinical suspicion is high and total T4 is borderline, free T4 by equilibrium dialysis is more accurate, and an elevated TSH confirms the diagnosis. The pituitary is screaming for more thyroid hormone that isn't coming. Hyperthyroidism in cats is the mirror image of hypothyroidism in dogs. Everything is revved up. These cats are eating ravenously but losing weight because a hypermetabolic state burns through energy faster than they can consume it. The heart is working overtime. Hypertrophic cardiomyopathy is a common secondary finding. On the chemistry panel, ALT and ALP are often elevated because the hyperthyroid state causes hepatic changes. Diagnosis is usually straightforward. A markedly elevated total T4 in an older cat with the right clinical signs is essentially diagnostic. But here's the most important clinical pearl. Hyperthyroidism increases GFR, which can mask underlying chronic kidney disease by artificially keeping creatinine in the normal range. When you treat the hyperthyroidism and GFR normalizes, creatinine may suddenly rise and reveal CKD that was hiding beneath the surface. Always recheck renal values 2 to 4 weeks after starting treatment. Cushing's disease is one of the great mimics in veterinary medicine. Because cortisol does so many things, excess cortisol affects almost every system. Let's reason through the lab findings from the hormone's known actions. Cortisol raises blood glucose by promoting gluconeogenesis, so mild to moderate hyperglycemia is common, and some Cushing's dogs tip over into diabetes. Cortisol suppresses the immune system. You get the stress leukogram pattern every time. Cortisol induces ALP production, specifically a corticosteroid-induced isoform unique to dogs, so the ALP is often dramatically elevated. Cortisol antagonizes ADH, so the collecting duct can't concentrate urine, causing PUPD and dilute urine. And the classic physical appearance, pot belly, muscle wasting, thin skin, bilateral alopecia, comes from protein catabolism and fat redistribution. Once you understand what cortisol does, the whole disease picture makes perfect sense. Diagnosing Cushing's is a two-step process. First, you confirm that cortisol is in excess. Then you figure out where the excess is coming from. For screening, the urine cortisol to creatinine ratio is collected at home. Stress of a clinic visit can falsely elevate cortisol, and it's highly sensitive. A normal UCCR essentially rules out Cushing's, but it's not very specific. Many sick or stressed dogs will have a high UCCR. The low-dose dexamethasone suppression test is the gold standard for confirmation. You give a small dose of dexamethasone and measure cortisol at 4 and 8 hours. In a normal dog, cortisol should be suppressed. In Cushing's, it isn't. Once you've confirmed the diagnosis, ultrasound is your next best step. Bilateral adrenal enlargement points to PDH, while a unilateral adrenal mass strongly suggests an adrenal tumor. Treatment differs significantly between the two. Diabetes mellitus is fundamentally a disease of glucose delivery failure. Insulin is the key that unlocks the cell door for glucose to enter. Without insulin, or when cells are resistant to it, glucose piles up in the blood while cells essentially starve. That cellular starvation is why diabetic patients eat ravenously but lose weight. Blood glucose rises until it exceeds the renal threshold. Then glucose spills into urine. You can smell the sweet urine. The body, sensing cellular starvation, starts breaking down fat for energy. And if that process accelerates, ketones are produced and the patient develops diabetic ketoacidosis, a serious emergency. Fructosamine is an incredibly useful monitoring tool. It reflects the average blood glucose over the previous 2 to 3 weeks, which gives you a picture of how well the diabetes is controlled, rather than just a snapshot of one moment in time. Insulinoma is the opposite of diabetes. Instead of too little insulin, there's too much. A functional tumor of the pancreatic beta cells keeps secreting insulin regardless of blood glucose level. The classic presentation is episodic. The dog collapses or seizes, usually after exercise or a period of fasting, and then recovers once they eat. The hypoglycemia is the key diagnostic finding. A fasting blood glucose below 60 in a dog with these clinical signs is highly suspicious. But here's the critical piece. If a patient has low blood glucose, insulin should also be low because normal beta cells suppress insulin production when glucose drops. If insulin is inappropriately normal or elevated during hypoglycemia, that's very supportive of an insulinoma. The amended insulin to glucose ratio formalizes this relationship. Ultrasound may or may not find the mass. Insulinomas can be very small, and exploratory surgery with careful palpation of the pancreas is often needed. The pattern recognition approach is your best friend with endocrine disease. The chemistry panel often tells you exactly which endocrine disease to consider before you even run a specific hormone test. A dog with a sky-high ALP, stress leukogram, hyperglycemia, dilute urine, and PUPD? That's Cushing's until proven otherwise. A middle-aged dog with hypercholesterolemia, mild anemia, and a dull coat? Think hypothyroidism. An older cat losing weight with elevated T4, high ALT, and a creatinine that was normal last year? Hyperthyroidism with possible masked-CKD. A young dog with vomiting, hyponatremia, and hyperkalemia? Addison's. Once you recognize the pattern, you choose the right confirmatory test, not a shotgun approach. And always remember, treat the disease, not just the number. Endocrine disease is one of the most rewarding areas of internal medicine because once you understand what the hormone does, the entire disease picture becomes predictable. Hypothyroidism slows everything down. Look for high cholesterol and low T4 in a lethargic dog. Hyperthyroidism speeds everything up. Check the kidneys before and after treatment in cats. Cushing's floods the body with cortisol. Look for that signature ALP, stress leukogram, and PUPD. Addison's is a cortisol and aldosterone crisis, low sodium, high potassium, and an sodium to potassium ratio that tells the story. Diabetes is insulin failure. Insulinoma is insulin excess. Reason from the hormone, and you'll always know which direction to look. Question 1, T4 was high, creatinine was normal. You treat the hyperthyroidism and the creatinine jumps to 3.1. The owner is alarmed. Did the medication damage the kidneys? What do you tell them and why did this happen? This is one of the most important and most emotionally fraught conversations in feline medicine. The owner thinks the medication damaged the kidneys. It didn't. Here's the explanation. Hyperthyroidism causes a high cardiac output state that artificially increases blood flow through the kidneys, keeping the GFR elevated and the creatinine falsely normal. When you control the hyperthyroidism, GFR normalizes and the creatinine rises to reflect the true and already damaged kidney function. The kidneys were already sick. The hyperthyroidism was just hiding it. Now the clinical decision-making gets nuanced. If the azotemia is severe, you may need to balance T4 control against renal perfusion. Some cats do better managed at a higher T4 target to maintain that extra kidney blood flow. It's a genuine trade-off, and it requires an honest, empathetic conversation with the owner. Question 2, high ALP, stress leukogram, PUPD, potbelly, everything screams Cushing's. But wait, this dog has been on daily prednisone for 6 months. Does this dog have Cushing's disease, and how do you sort this out? This is a classic trap, and it's one you'll fall into exactly once before you never forget it again. Everything about this dog's presentation looks like Cushing's, and it is in a sense. Exogenous glucocorticoids cause exactly the same clinical and laboratory picture as naturally occurring Cushing's disease, because the mechanism is the same. Cortisol excess, but the cause is external. You cannot run LD-DST or HD-DST while this dog is on prednisone. The results will be uninterpretable. The way to distinguish iatrogenic from endogenous Cushing's is endogenous ACTH measurement. In iatrogenic cases, the pituitary is suppressed by all those exogenous steroids, and ACTH will be very low. On ACTH stimulation, the adrenal glands will respond poorly because they've atrophied from chronic suppression. Management is to taper the prednisone gradually, never stop suddenly, because those atrophied adrenal glands cannot produce cortisol on demand, and the dog will crash into an Addisonian crisis. 3. Boxer episodic collapse after exercise, recovers spontaneously. Blood glucose of 38 during an episode, profoundly low. But look at that insulin level. At a glucose of 38, what should insulin be, and what does 42 tell you? This is a classic insulinoma presentation, and the numbers tell the story perfectly. When blood glucose drops to 38, every normal beta cell in that pancreas should be completely silent. Insulin should be near zero. Instead, it's 42. The tumor is pouring out insulin regardless of blood glucose, like a faucet that's stuck open. The amended insulin to glucose ratio makes this quantitative. A ratio of 525 is enormously above the diagnostic threshold of 30. This dog has an insulinoma until proven otherwise. Ultrasound is the first imaging step, but small insulinomas can be invisible on ultrasound. CT is more sensitive. These tumors are often small but malignant, and metastasis to regional lymph nodes and liver is common by the time of diagnosis. Surgical resection gives the best chance of prolonged survival, but medical management with frequent small meals and prednisone can buy meaningful quality time even when surgery isn't an option.